confronted with such a visual field defect, or more aggressively, this visual field defect. So in this visual field defect, for example, this is 24-2. You can see it's not a complete rounded circle. This is 32, but this is 24-2. So if we start with this patient, for example, this patient shows, you can say it's bitemporal hemianopia. But if you are very clever in reading visual fields, you'll know that this left eye shows hemianopia extending to the other side. So this is more of a central hemianopia and central scotoma. You are trying to find hemianopia in the other eye, either contralateral or ipsilateral, but what you find is an enlarged blind spot. Let's go back to the first case, and we just mentioned that this is an enlarged blind spot, and this is another form of enlarged blind spot. So an eye with unilateral hemianopia or central scotoma and contralateral superior temporal scotoma or enlarged blind spot is called junctional scotoma. Of Traquair. Traquair wasn't French, he was Scottish. So Dr. Traquair described the junctional scotoma as unilateral hemianopia or central scotoma associated with contralateral superior temporal scotoma or enlarged blind spot. This formed what's called, or what's known as, distal optic nerve syndrome or anterior chiasmal syndrome. It's simply due to compression on the distal optic nerve or the anterior part of the chiasma. And again, what might cause this? It might be caused by space occupying lesion, and you can of course enumerate aneurysm of the carotid artery or anterior communicating artery, glioma, meningioma, demyelinating disease, might cause it as well, pituitary tumor or adenoma, and adenoma is the commonest, most common. So because of this constellation of causes, the visual field might change. So the junctional scotoma might take the form of complete blindness of one eye, which is complete affection of the optic nerve on one side associated with superior temporal scotoma. Simply, we can draw it here, the visual pathway So this is the optic nerve from one eye, and this is the chiasm. Temporal fibers. The nasal fibers are not a problem. So the nasal fibers just have an ipsilateral tract orientation. It goes to the same side. While nasal fibers are postulated to cross in the chiasm. And rather than crossing in this direct pathway, they might form what's called knee of von Willebrand. So they run anteriorly into the contralateral optic nerve for 1 to 2 millimeters up to 4 millimeters. And this is a reason why compressive lesions on the distal optic nerve or the anterior chiasma affect vision ipsilaterally and contralaterally. So these nasal fibers are concerned with temporal visual field on the other side. So on one side you can find unilateral hemianopia, or you can find central scotoma, or a combination of both. And on the other side you can find enlarged blind spot or superior temporal scotoma from these nasal fibers. The anatomical evidence for knee of Willebrand are not well established. So some recent anatomical studies mention that they are not present in normal population. They are present in a person who had an enucleated eye, so enucleation of one eye, for example, leads to retraction of these fibers into the contralateral optic nerve. However, there are anatomical variations, and these are well proved. So junctional scotoma of Traquair is something that's well established. If we continue with the anatomical